Hello, everyone, and welcome to today's webinar, Understanding and Managing Anemia and CKD.
The Kidney Foundation would like to thank our sponsors of the 2021 webinar series, Alexion, AstraZeneca, Horizon, Janssen, Otsuka, and Paladin. Anemia is a condition in which you do not have enough healthy red blood cells to carry adequate oxygen to your body's tissues. There are many forms of anemia, so it can affect people differently depending on how severe it is. As the condition worsens, it may lead to low energy, tiredness, shortness of breath, and sometimes increased sensitivity to cold. If left untreated, anemia can cause serious health problems. Seek treatment so you can better understand the cause of your anemia, boost your energy, and feel better. This webinar will explore anemia in great deal, including related signs and symptoms, medical testing, and treatment options. Teresa Atkinson will talk about the impact of anemia on her and her family and how they have managed the condition. Dr. Dan Martinson, Pharmacist and Provincial Director with BC Renal, and Dr. Darren Richard, Director of the Biomedical Sciences Program at University Laval, will also take part in the discussion. Before we begin, I would like to acknowledge that I'm located in East Toronto, which is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Haudenosaunee, and the Wendat peoples. It is covered by Treaty 13, signed with the Mississaugas of the Credit, and is still home to many First Nations, Inuit, and Métis peoples. Recognizing that we all work and live in different places, and that you may be joining us from a different traditional Indigenous territory, I'd like to encourage everyone to take a moment to reflect on that and acknowledge it. If you know the territory in which you're situated, I invite you to acknowledge it in the chat. The information shared in today's webinar is current as of today, November 3rd, 2021. The material shared in this presentation is not intended to be medical advice. You should speak to your doctor about your own individual situation. This information is intended for a Canadian audience. We are thrilled to introduce our speakers today. Thank you all for making the time to share this important information with us. We have a lot of content to cover, so please visit our website to read the complete bios. Teresa Atkinson. Teresa's kidney journey began with a crash. At 22, her kidneys failed without any warning. She woke up in the intensive care unit already on peritoneal dialysis. Teresa has survived many more years on dialysis than with a successful transplant and has undergone all forms of treatment available, including PD, hemodialysis, both in centre and nocturnal at home. After 17 years, she is living with her third transplant. Teresa has battled anemia throughout her 35-year kidney journey, and even with the transplant, anemia continues to be an ongoing issue. Dr. Dan Martinson. Dr. Martinson graduated from UBC, then completed a residency at Lionsgate Hospital in North Vancouver and earned his PharmD from University of Washington. He became involved with the renal program at the Royal Jubilee Hospital in Victoria and has chaired the Pharmacy and Formulary Committee with BC Renal since 2001. He has been involved in numerous projects, resulting in conference presentations, posters, publications, and awards. He has been awarded BC Renal's Award for Outstanding Contribution in the Care of People with Chronic Kidney Disease. He is also a Fellow of the Canadian Society of Hospital Pharmacists. His main interests are improving outcomes for same or reduced costs at the patient and population level. Dr. Darren Richard obtained his doctorate in pharmacology from University de Sherbrooke in Quebec and his postdoctorate in cell biology from Université de Nice in France. A researcher at the CHU de Quebec Research Centre in Quebec City since 2001, Dr. Richard is a full professor in the Faculty of Medicine and University Laval. His field of research concerns oxygen sensing, hypoxic signaling, and their role in cancer, kidney disorders, and cardiovascular disease. Fellow of the Fonds de Research de Québec Santé and the Canadian Institutes of Health Research, Dr. Richard has participated in numerous national and international scientific committees. Dr. Richard is presently the Director of the Biomedical Sciences Program at University Laval.
Hello, everyone. My name is Teresa, and I'm a 35-year kidney patient. So I'm going to share just a little bit about me so you can understand where I come from. I was raised by an American father and a Canadian mother. I was the oldest of two sisters who were really close in age. There was only 3 years between us. And of course, a much younger surprise brother followed when I was 20 years old. I had a wonderful childhood and was raised to be a bit of a daddy's girl and a tomboy. As my father and grandfather were fishermen, our whole family spent the summers in Alaska fishing, commercial fishing out of the Gulf. At sea, of course, doctors were only for emergencies. So I learned to be self-sufficient and grew up sucking it up. Unless it was serious, you didn't go to a doctor. We, of course, spent our winters where my dad grew up, which was Camino Island, Washington, and then Canada being my second home. We spent many holidays with our numerous relatives on my mom's side. So as a young woman, just out of college, I moved to my second home and settled down in the Vancouver area. Several years ago, we had the privilege to move to the BC interior, and I now live, work, and play within the ancestral, territorial, and unceded territories of the Syilx Okanagan Nation. My husband and I raised his daughter, my stepdaughter, and we've been blessed with 4 grandchildren we get to enjoy. I've volunteered with the Kidney Foundation for 25 plus years. And as a person with a lifetime of lived experience with chronic disease, I'm passionate about advocating and empowering others and building our community. Connecting with others has always helped me along my kidney journey. My professional background is in administration and project management, so I'm lucky enough to be working on a part-time fixed-term position with the BC and Yukon branch of the Kidney Foundation as a project coordinator and liaison. So now on to my story about living with kidney disease and anemia. Have you ever overexerted yourself so you couldn't catch your breath and you had to sit down and recover for a while? That's what living with anemia can feel like sometimes. Of course, some days are better than others. It's always changing. So Lydia shared my kidney journey started with a crash and I woke up in the hospital, so I'm going to skip that part. There's no history of kidney disease in my family, and I didn't know anyone who had kidney disease. So it's assumed that I had extremely high blood pressure at my young age, and that caused my kidneys to fail. I had been to the doctor and they had tested my blood pressure and found it high, but they assumed it was white coat syndrome. It really wasn't understood how vital controlling blood pressure was to protecting your kidneys at that time. This was 1984. So as soon as I was stable, as some of you will know, if you're patients, there's all kinds of things to learn as a kidney patient. You have to learn how to follow a kidney diet, low in phosphate, potassium, and sodium. There's medications that you take to help manage that and other diseases like high blood pressure. I had to limit my lifting because I had a PD tube and I couldn't go swim anymore, which I absolutely loved. So that was a bit of an adjustment, but something I could live with. I didn't know yet, but I now had anemia. I was able to manage somewhat of a normal life, but I still had a lot of rest breaks. I had to take an afternoon nap. I was tired all the time. I could never sit through an entire movie without falling asleep. It felt like I was working as a deckhand, which I would relate to working on the fishing boat with my father, but it was like a physical job, 18 hours a day is what it felt like. At this time, EPO wasn't even available until 1987. So the only treatment for anemia when I crashed into kidney failure was a blood transfusion. And being a young person on the transplant list, they didn't want to give blood transfusions because that would create antibodies for me and prolong my wait for a kidney. So also being a younger patient, I may need more than one kidney. And these were things I didn't know yet and would learn later on in my journey. Once EPO became available, it did improve things at this point. I still struggled with my anemia though, because of my iron was low and I was stubborn. I didn't tolerate the supplemental iron and I refused to get an IV so they could give me IV iron, something I wouldn't do now in hindsight, but that was just my ignorance at that time. I remember thinking kidney disease wasn't so bad. I could survive a few years of dialysis until I got a transplant and got my life back. Well, almost 6 years later, my then fiance and now hubby and I were just finishing up dinner and the phone rang. They had a kidney for me. Could I come to the hospital right away? The doctor asked. I was excited. This was it. My wait was over and I was going to get my life back. When I got to the hospital, they double-checked the match and I went into surgery a few hours later. Unfortunately, when I woke up, I didn't feel much different and this kidney never really worked. There were many complications and I was back on dialysis within a year. So at this point, I realized kidney transplants weren't a cure, just a really good treatment. But I was confident I could wait another 5 to 7 years to get a second chance. Then, however, I took a turn for the worse. I really wasn't doing so well. I was in hospital and the team couldn't figure out what was wrong with me. I remember them asking me, what day is it? And I was thinking in my head, Tuesday. And I concentrated for a while and Saturday come out of my mouth. I knew it was wrong. And it turns out it was anemia. It probably was the scariest thing I ever had in my current kidney journey. And I'm really glad I was in the hospital at that point so they could treat it. So then my sister stepped forward to be tested because I wasn't doing well. And I still struggled with the idea of accepting her kidney. It was hard. She's my younger sister. She hadn't had a family. And I worried about her health or the health of a potential niece and nephew. Finally, she said, I'm not giving my kidney for you. I'm giving my kidney for me. I want my sister back. That convinced me. So at age 29, my sister gave me one of her kidneys. This time, I woke up with an appetite I hadn't had in years, and I was peeing buckets. Her kidney worked instantly, and my health and energy returned. This is the only period during my kidney journey that I didn't struggle with anemia. As a side note, my sister did go on to produce 2 nephews, and she had to have a bit of bed rest at the end of her second pregnancy, but there were no other ill effects to her health due to her donation. There wasn't a day go by, though, that I didn't worry that I might accidentally do something to lose her kidney. So we were on an annual shopping trip to Seattle, which we did, and it happened. I got sick. I couldn't keep my medications down. Knowing keeping medications down is vital to keeping a kidney, I went straight to VGH and they confirmed I was in rejection. My sister, however, she was a gem. The only thing she ever said when I lost her kidney was, has research advanced enough to cut one in half so I can share my other kidney with you? At 36, they took both transplanted kidneys out so I could get off the anti-rejection medications. They knew another transplant wasn't anytime soon, and I lost hope that a transplant would ever be in the cards for me. I tried at this time to go back to peritoneal dialysis, but my peritoneal cavity wouldn't work anymore, and I had to transfer to in-center hemo. I'd always said I would do this only over my dead body. But of course, when push comes to shove and the only other option is dying, I chose hemo. This meant I couldn't go away for more than a weekend, though. I couldn't spend a week with my family somewhere. I lost my independence and control, managing my own dialysis and my own schedule. That was a very difficult transition for me. Additionally, I have very small veins, and all 3 attempts to build a fistula failed. So I had to live with grafts. And grafts aren't meant to last for very long. They last a year or 2 generally, and they're much harder to needle. It usually took multiple pokes for me to get hooked up when I went to dialysis. So I was really not doing well and ready to give up on living when my doctor suggested I needle myself. I was shocked. This wasn't being done anywhere I knew about. How could I learn to needle myself? And I couldn't at first. I really struggled, but then I learned. And it's probably one of the best things I ever did for my long-term survival. It gave me back my control, and doing it yourself is not nearly as painful as having someone else do it. You can stop if it hurts. However, in-center hemo wasn't a good match for me. After they'd removed the transplanted kidneys, I no longer produced any urine. I didn't pee at all. So I needed more dialysis, and I feared I wasn't really going to last very long at this rate. So at this time, there were IV iron and EPO injections. I took it. I could take and did take, but due to my grafts, I couldn't bring my hemoglobin up very high because it would cause my grafts to clot. And of course, that's my access, my lifeline. So I would purposely keep my hemoglobin just under 100. This was more difficult to manage. Now I'm tired all the time and I'm struggling to breathe. I had to schedule lots of rest breaks, break down my projects into smaller chunks. For example, instead of vacuuming the whole house, now I just do one room at a time and take a break in between. But that was okay. The hard part was, even though I had plans, I often had to cancel them because I was just too exhausted. I just ran out of energy by the time it came time to do something with family or friends. I always felt terrible, but they always understood. I learned tricks to improve my iron because keeping your iron up is one of the important things to building your anemia. It takes that as well as the EPO. And frying out of a cast iron pan really helped me, as well as, of course, eating the higher iron foods. I remember there was one day, my stepdaughter, Jennifer, she was about 10, and she asked me, why could I have the energy to go bowling and I couldn't help her scrub the floors? And I had to explain to her, it's like you have a limited supply of energy, which we all do. And I had to manage it like you would a budget. Of course, she got that. She didn't like it at 10, but she got that. So that's how I managed when I had very low anemia. I lost hope at this point of ever having a normal life again until a new pilot program came on called nocturnal dialysis, where I could actually take that hemodialysis machine home and dialyze most nights while I slept. It provided a treatment that was much more like a normal kidney would function. And in the morning, the doctors really couldn't tell that I had kidney failure if you looked at my blood work. I still would have to keep my hemoglobin low, but at least I could have more of a functioning life, and I was doing better with lower creatinine levels. So of course, my medical team refused to give up on the idea of a transplant and convinced me to go for assessments about every 5 years. And I went, but we always agreed that I was doing well on nocturnal and I should wait and hope that research would improve treatments for transplantation. It was on the 3rd visit, and I'm running out of my dialysis access because of my small veins. So rather than giving up, I agreed to go on the transplant list and look for a living donor. Now, I was highly sensitized from rejecting both kidneys, as well as a bunch of blood transfusions that I had to have because my hemoglobin was low, or the surgeries that I had for dialysis access. So the chances of finding a kidney were about 50-50. So I continued to live on dialysis for the next 17 years. And at 53, 31 years after I crashed into kidney disease and 17 years after I lost my kidneys, my sister's kidney, I got a call. I was one of the lucky ones. They'd found me a match and I was still in good enough shape due to nocturnal dialysis to accept the kidney. This time I went in knowing I had no control of anything, only hope. I expected them to throw everything at me to make this kidney work, and they did. There were extra medications given and complications, including dialysis for 10 days after I was transplanted, but then the kidney woke up. And even though it's a low functioning kidney, it's keeping me alive. But with this kidney, I still struggle with anemia. And I took EPO injections for the first year, but then they thought the kidney would kick in. And I've been living with it now for 5 years, and it's on the low side. About 106 is my hemoglobin. I've found that small bursts of exercise help me maintain my stamina and keep my breath, but it takes me longer than most people to do anything, and I struggle with exercise because of it. Now that I've been asked to share my story, though, here, I'm going back to my medical team to see if I can't do some of the treatments, because now I know if I do IV iron and get EPO shots, I can get my anemia up and my energy level back where it should be. Kidney disease has taught me life is too precious not to enjoy the moment. We don't know what life is going to give us tomorrow, and you may have abilities taken away or you may have abilities given back. Surviving well with kidney disease requires learning and adjusting to new things each step of your journey. But that's not just kidney disease, that's life in general for everyone. Thank you for letting me share my story. And over to you, Dan, for a little bit about the EPO and the iron.
Thank you. I'd like to share my screen. Okay. So thank you, Teresa. That's an amazing story and something that I could never represent, and just the incredible journey that you've traveled on. I'm speaking to you today from the Algonquin or Songhees traditional and unceded territory in the Esquimalt nations, which we now call Victoria. So I thought I'd just share my presentation as sort of questions that people might have and then answer them. And it skims the surface, but hopefully it prompts maybe more questions from you. And we can have more of a dialogue later when we return as panelists. Teresa's story may have prompted some questions for you, but hopefully we can walk through those and have a good conversation. So I will present on the current state of anemia care and therapy, and then Dr. Richard will comment on some things we might look forward to in 2022 and beyond, the next steps. So what is anemia of chronic kidney disease? You know, anemia generally, I think, is the second most common diagnosis worldwide, or sign or symptom, pain being number one. Anemia comes in many forms and for many reasons. Certainly nutritional deficiency is probably the leading cause, but anemia of chronic kidney disease is a specific type of anemia, and it is an iron deficiency anemia, but it is also complicated by a lack of what we call erythropoietin, which is a hormone that's normally produced by the kidneys, or more, about 90% of it's produced by the kidneys. Symptoms tend to develop slowly, and people with diabetes and those who are over 60 may experience it earlier or more frequently. There's some some subtypes of kidney disease or the reasons for kidney failure, such as polycystic kidney disease, where the production of erythropoietin might be preserved to some degree, so they may require none of that or less. But certainly it is profound, as Teresa reports: fatigue, tiredness, shortness of breath, unusually pale skin, weakness, can include body aches, can include chest pain, dizziness upon rising, fainting even, fast or regular heartbeat. And really all of these things are related to the tissues and the organs may not be receiving as much oxygen as they would like. And so that can also translate to headaches, sleeping problems, trouble concentrating. So in short, the quality of life is really not there for untreated anemia or undertreated anemia. Now, anemia is less common in early kidney disease and tends to worsen as kidney function is lost. And that's it really relates to the erythropoietin being produced less and less as kidney function is lost. So what does my kidney team look to guide therapy? Pardon me. So anemia is a condition in which the blood has fewer red blood cells and less hemoglobin. And as I mentioned, there's a number of reasons why anemia can be. The hemoglobin, just to orient you, that is the molecule where it incorporates iron and uses iron to carry oxygen in red blood cells from the lungs to the rest of your body. So we do conduct routine blood count tests to monitor this. And those routine blood tests also give us a signal that if the anemia is for another reason or if something else is going on in the blood, we can detect that. But with respect to anemia of chronic kidney disease, there's really three main iron or main blood numbers that we look for. One is the hemoglobin, so that's the ability of the red blood cells to carry oxygen. And the other two relate to iron. So there's ferritin, which is the stored iron in your body. And you can think of it as iron in the tin to remember ferritin. And so that's what we think of as the total body stores of iron. And then what we call the TSAT, you may have heard of that, or transferrin saturation. And that's the ability of the body to move the iron from the storage area to be incorporated into hemoglobin. So your body needs to have good stores of iron, and it needs to be able to move or mobilize that iron to be incorporated into hemoglobin. So those are the three that we sort of use primarily to guide anemia. But of course, nutrition is important in treating or maintaining, treating anemia or maintaining good health. And so we also measure vitamin B12 and folic acid or folate, which also is a B vitamin, and we'll replenish those. And commonly, there'll be a multivitamin specifically formulated for kidney patients that may be prescribed, and it might be Replavite is a common name. It's essentially water-soluble vitamins, which may be lost in the event of either dialysis or your diet may not be replete enough. So why me and what can I expect? So Teresa covered the why me, but just to remind that as your kidney disease worsens, your chance of anemia increases. And so I would say that most people with a kidney function of less than 15%, or what we call an EGFR of less than 15, will have anemia. More than 1/7 people with kidney disease have anemia, and so this is even an early kidney disease. Looking at all people with kidney disease, it's sort of that common. And as I mentioned, people who have diabetes and those who are over 60 will be more likely to have this type of anemia. It might be said that patients who are on dialysis almost universally have anemia that we need to treat, either just with iron or with both iron and an erythropoietin type product. So what's important to know is that, we are on your team and we want to help correct your anemia for your quality of life and to improve the oxygen delivery to your tissues and organs. You should additionally know that additional blood loss, malnutrition, infection, if you have any sort of chronic inflammation, may also make anemia worse, and so also should be addressed. Cancer, some cancers can also make anemia worse. So we want to pay particular attention to all these other things that might contribute so that we're aware of them. And you'll be presented with various therapies and strategies to treat anemia. From the polling question, a number of you are on some form of treatment for anemia. And so we'll go over some of those. And early in kidney disease, the anemia will likely be treated with oral iron. A number of oral iron options exist. As Teresa shared, she couldn't tolerate some of the oral irons, and so that was unfortunate. But there are options, and we'll talk about that maybe there's an oral iron that will work for you. Generally, what we try to go for first is the tablet with the highest elemental content with the lowest price. So a generic or house brand ferrous fumarate 300 milligram tablet would be one that we'd probably reach for first. Others include ferrous sulfate or ferrous gluconate, and they contain lower amounts of elemental iron. And the gastrointestinal side effects are related generally to the elemental iron content. So the more elemental iron, you're more likely to experience those side effects. Other irons include what we call a heme iron as a tablet, and that's incorporates sort of a hemoglobin-ready iron that is much more readily absorbed and utilized by the body than one of these, what we call salts, the gluconate, sulfate, or fumarate. And then there are iron complexes that are either put in sort of a matrix or coated generally, sort of to help protect the stomach or to reduce those side effects of oral iron. Unfortunately, with those complexes, not only do they reduce the side effects of iron, but they also reduce the amount of iron that's ultimately absorbed. So they tend to be expensive and don't provide really any advantage other than, well, we could use a lower dose of one of these salts to maybe give you the same amount of iron that you might get from one of these complexes. So as kidney disease worsens, as Teresa also shared, intravenous irons may be necessary, or if you can't tolerate the oral irons. And this, oral irons, we can give you a replenishment amount up to a certain point, but I would say that most people who are on dialysis will require an intravenous iron. The options include iron sucrose, iron gluconate, or ferric derosamaltose, which is a newer injectable iron. So these are all, you can gather maybe from the names, these are sort of sugar incorporated iron formulations. And they, by putting them in this fashion, they allow for a dose to be given that releases the iron more slowly, and so will reduce the side effect profile of these injectable irons. And you may also be asked to inject erythropoietin or darbepoietin as well. And this really, you can think of a person with diabetes who needs insulin because the pancreas is not producing insulin anymore. What we are doing here is replacing the hormone, the erythropoietin, that your kidneys normally would have produced. So the erythropoietin is a human form of the erythropoietin, and darbepoietin is just slightly modified to give it a longer duration of action. So erythropoietin might be given 3 times a week or as little as once a week, whereas darbepoietin would be given once a week or maybe as little as once every 4 weeks. So this is just demonstrating the different iron products available. So you can see the ferrous fumarate has 100 milligrams of elemental iron per tablet, the sulfate 60, the gluconate 30, and heme iron comes in 11 milligram tablet. So you can't really compare that to the others because it's between, like comparing apples to oranges. The heme iron is more readily available to be absorbed and also to be taken up into hemoglobin. So the dose is an 11 milligram tablet. Iron sucrose can be given anywhere from 1 to 500 milligrams intravenous, and that's as elemental. The 500 would be a fairly big dose, so some institutions limit it to 300. Iron gluconate can range 62.5 to 125 milligrams, and this is expressed as elemental. And this newer iron, the ferric derisommaltose, can be given anywhere from 500 to 1500 milligrams intravenous as elemental, and most people would have a 1000 milligram dose. What's potentially nice about that one, fewer visits into a clinic or a hospital would be required because the dose is that much bigger. So you might go once or twice a year as opposed to every month or two. So are there any side effects or long-term effects? And so some of the unpleasant side effects of oral iron can include stomach upset and pain, constipation or diarrhea, so one or the other, nausea and vomiting. So clearly, if we can minimize those side effects, we want to. It is safe to take, but everything is in the dose. So if the 100 milligrams of elemental iron, the ferrous fumarate, is problematic, then we can maybe try a ferrous sulfate or a ferrous gluconate to reduce the amount of elemental iron. A lot of these tablets are formulated that you can't really split them because they're roundish and would probably, if you tried splitting, it would shoot across the room. So we would change the actual salt that we use. Intravenous irons are generally well tolerated. A few people do get side effects and quite unpleasant side effects, so we monitor for that. And so some of the side effects that can be experienced are nausea, cramps, dizziness, certainly if getting up quickly, so we monitor and have people wait for a period of time after getting the infusion. Rash, problems with breathing, swelling of the face, arms, and legs. And these last few are getting to be more rare, but we carefully monitor for these side effects. And there's a couple of things we can do. We can try a different intravenous iron because we have options. But additionally, if you tend to get a headache, for instance, or if you tend to get a rash, we can offer some pre-treatments, say like a diphenhydramine or Benadryl for the rash. You can take that a bit before, or some Tylenol to help with cramps or headache. So there's some options we can offer to minimize the impact. As far as erythropoietin and darbepoietin, they are, I would say, extremely well tolerated. In larger doses that were used in the past, there was a potential, and Teresa alluded to this with the clotting in her graft, that was the potential for increased heart attacks, hypertension, high blood pressure, and stroke. And that you can imagine the blood getting thick with red blood cells, for lack of a better word, whether it's a clot in the catheter or the graft or some of these other side effects, we limit the rise of hemoglobin today by using smaller doses. And we've learned a lot about these two drugs over the last 30 years. So we do use them, and patients who are not yet on dialysis, we tend to use them a little less often in lower doses than patients who are on dialysis. So how do I take my medications to get the most benefit? Well, oral irons are ideally taken on an empty stomach at bedtime. Do not take them with anything to do with calcium, because calcium will what we call salt out or complex or bind to the iron. So this includes if you take a Tums at night because of heartburn, that's calcium carbonate. If you take dairy, like a glass of milk at night, or other supplements. So do not take them within 2 hours. And the notion about bedtime is that generally you're not having anything at bedtime. And if you do experience some unpleasant GI side effects, you might be asleep and not be as aware of them. But don't suffer in silence. If you do experience side effects, talk to us about it, and we can discuss alternatives. Interestingly, even coffee or black tea should not be had within 2 hours after taking oral iron. So if you have a nighttime cup of tea, beware of this. You can actually reduce the absorption of iron by up to 40%, even with these two beverages. So I would avoid taking coated irons. They do reduce the GI side effects, as I mentioned, but they're also less well absorbed. And if you do have GI upset, start with a lower dose. And honestly, some food might work, even though I recognize we're reducing the amount of iron that's getting absorbed. Some iron's better than no iron if you can't take these. So work with us and let us know how you're taking and how you're doing with that, and we'll monitor your blood for the iron. Now, the IV irons will be administered by nurses in a clinic, so it's less problematic for what you have to watch out for, but be aware that after the infusion, take it a bit more slowly to make sure how the iron has affected you, and by all means take advantage of the wait time afterwards in the clinic just to have a check-in with yourself. Now, the erythropoietin products, so the epoetin, darbepoetin, are in a pre-filled syringe, and your team will instruct you how and when to use these. There are a number of different doses that are in the pre-filled syringes, so a wide range for the dose that's right for you. An important note, they must be refrigerated right from the manufacturer, and ideally up until almost into your arm, but they are managed with what we call a cold chain requirement, so they must be refrigerated. These are biologic products, and if they're left out of the fridge for a period of time, they will not be as effective and may cause additional problems. So please pay particular attention to that. So is there anything else I can do? Well, if you do have a registered dietitian, or if your kidney program has a registered dietitian that's available to you, take full advantage of that. While Teresa said that she tried to take foods that gave her iron, there are foods that are high in iron, vitamin B12 and folic acid, and they can be added, but they may also have high amounts of protein, sodium, or phosphorus. So it's a balancing act to get it right. And the dietitian is a wonderful resource that you should take advantage of. Blood transfusions. Teresa predated the arrival of the erythropoietic hormones. So that's what was commonly given. And we try to avoid these as much as possible. And finally, I just want to say that if you manage blood pressure and you manage diabetes and other conditions that speed the decline of kidney function, by doing so, you'll also be delaying anemia or the symptoms of anemia and preventing it from getting worse. Because as the kidney function declines, the amount of erythropoietin that's available also declines. And so I'll leave it there for Dr. Richard to talk about some exciting new developments on the new treatment side, and look forward to your questions when we all come back for a panel discussion. And with that, I'll stop sharing my screen.
Hi, Teresa.
Hi.
I just wanted to say, I've been doing research for quite a while, and we kind of get lost in it. Okay, we kind of get lost in the lab and our stuff. So I really, really appreciated your presentation and what you've been through. And you're one of the reasons that I do my research. So thank you very much. And
Thank you.
hopefully there's things that I'll say that you'll be able to understand a little bit, maybe a little bit better about certain of your reactions and certain of your questions and what you've been through. So hopefully I'll be able to do that for you.
Awesome. I'm excited to hear the presentation and see what's new and coming.
Actually, it's not that new. And that's the thing, it's not that new. So I've been doing this research for about 25 years and on this subject. So we know how it works, and it's how to get it to the patient that's the big deal. So it takes a long time. And that's what I'll try to get through to you today. And I work on hypoxia, and I've been working on hypoxia, like I mentioned, for 25 years. And hypoxia, obviously, is oxygen and how we get our oxygen and how we use it. Okay. And we're always in the mountains when we were looking at hypoxia, because actually a lot of the studies, when they do it, they on this medication that I'm going to talk about, they give them mountain range names. So it's, you know, it's right on the reality of hypoxia. And I just want to mention hypoxia and what it is. Okay, so hypoxia, or what is oxygen homeostasis? So oxygen, what it is okay, you know what normoxia is. You know what oxygen is in the atmosphere. You have 20% oxygen in the atmosphere. However, what the tissues see, it's what we call physioxia, okay? And it's specific to each tissue. We'll see that a little bit later. So hypoxia, it's when the tissue oxygen levels decrease under the physioxia. And if there's hyperoxia, where there's more oxygen, which is quite rare, okay? It's usually this situation that we see. And this situation normally will cause situations like anemia. So what's important is that balance. And how do we get the balance? And how can we maintain that balance? And that's something, Teresa, I think that you've been trying to do for quite a few years now. So to show you quite rapidly, I won't go into detail here. And if I explain things a little bit too quickly and you don't understand, you can always ask me a question later on, but I'll try to keep it simple. So basically the tissues, like I said, have specific oxygen levels, okay? And what's really important is to look at the kidneys. And why are the kidneys so important to basically detect oxygen? And why, when we have kidney problems, we start to have problems with oxygen levels and we start to have anemia? Well, it's caused by a gradient, okay? It's caused by an oxygen gradient. And this oxygen gradient is created by a situation which is basically the physiological role of the kidneys, which is to filter. And as they filter, it creates a gradient in the kidneys from the outside of the kidney towards the inside, where the filters are, and to where the urine is produced more towards the center of the kidney. So this gradient, caused by the situation of filtration, causes this gradient in oxygen. So that's the way the kidneys are able to say, okay, there's so much oxygen in the system and I have to respond or not. If you have a diseased kidney, obviously you lose this. You lose the filtration and you lose the gradient and you lose the possibility, the kidney's basic function in detecting oxygen. It's the same thing that goes on here. So this is my wife. This is Tanya. And Tanya she likes to climb mountains. And she likes to climb mountains, but it causes her problems, okay? Because as the climbing the mountain, so this is Kilimanjaro. So at Kilimanjaro, there's only about half of the oxygen available for her to be able to breathe. And she'll react to that. To react to that, actually, which reactions are very, very similar to what we heard that are symptoms in anemia. So what she has is a high heart rate. So her heart beats very quickly. Her breathing increases to be able to get all that oxygen, or that limited oxygen that's there. She has fatigue, she has pain, and she has very cold extremities, and she's losing the feelings at the end of her, and she is basically a little bit white, you can see. So what's interesting is that all this, you know, this is the body's reaction not having enough oxygen to function. And in her case, she has good kidneys, so she's able to react to that quite quickly and to put in motion a response that's going to be able to maintain her oxygen levels and to maintain basically survival at these altitudes. And so how does this work? Well, we heard it from the start. It works through EPO, and I'll call erythropoietin EPO. So basically what goes on is oxygen is low, your kidneys respond to this, produce EPO. EPO goes up into your blood system, binds to its receptor, which is found on red blood cell precursors, so the cells that become red blood cells. That's in the marrow. And so these blood cells are basically increased. So they develop into mature blood cells. And then more blood cells, you're able to bind more oxygen and to bring more oxygen into the system. More oxygen makes it to the kidney, and the kidney detects this increased oxygen. So the system says, okay, I have enough oxygen, so I can bring down the EPO, and then I have my good response. And now I'm able to, the organs are able to survive. What happens in CKD? Like I said from the start, your kidney function is lost. You lose this gradient of oxygen. You lose the sense, your problem in sensing the oxygen, loss of EPO, a loss of blood cells, you have lower blood cell counts, and then you have problems to maintain your tissue oxygen levels. So the symptoms are all basically the same that we mentioned from the start, from what Tanya is undergoing here in a situation of hypoxia at high altitude. So we heard them from the start. I won't go through that again, but you can see that these symptoms are all linked to the situation that there's not enough oxygen. How do you treat it? EPO. We heard about EPO and all its effects. I won't go into that at all. These compounds were developed specifically to treat anemia, and they work very well to do that in most patients. We heard that there's in Canada, there's EPREX and RNS. We heard what they are, so I won't go into detail. There's advantages. The advantages, we heard them from the start, but there's disadvantages that we also heard, that because it's an invasive administration, it's more complex patient management. We heard about this also. It's a protein, and it's a compound that has a limited shelf life, so it's very important to be able to maintain the quality of the product. Dosage is very, very, very important. I know people like Dan work on this quite a bit to be able to find the right dosage for the patient. And there's also quite a few detrimental off-target effects that unfortunately occur, because basically EPO does more than just increase red blood cells. So there's EPO receptors on other cells, and there's different responses. The often response that you see are inflammatory disorders, hypertension, even possibilities of cancer progression. And also in the end, like you mentioned, anemia is a lot more complicated than simply EPO. So you never get a complete reversal of the anemia. So how can we get this complete reversal of anemia, or at least attempt to be able to get it? Well, we have to go upstream from EPO, because the response, like I said, it's in the kidney. It's how the kidney is producing this EPO. And the way it's producing it is through factors, okay, which are protein factors that basically they're in the cells and they bind DNA and they activate the production of proteins. And the protein, one of the main proteins is EPO, okay? We call them hypoxia inducible factors, HIF. So HIF, what's interesting is that, like I said, I've been working in this field for 25 years now, and so have these people. And what's interesting is that the field, as it developed, we noticed that it was very, very important, obviously. And our field basically received the Nobel Prize in 2019. So I just wanted to say that. And these are my 3 colleagues. When I started working on this in this field, we were just 6 groups working on it. So, and now there's quite a few groups working in this area. So I won't go into too much detail to explain what HIFs are, but basically they're complexes, they're protein complexes. And these protein complexes are very specific in what they do, okay? And they're found in every cell, okay? All cells have a HIF complex, and they'll respond to decreases in oxygen. So basically every cell, every tissue, every organ, okay? And the complexes are the dimers, so there's 2 proteins, and alpha and the beta. Why is it important that I tell you the alpha and the beta? Well, the beta is always there. It's on all cells. What's important is this alpha guy. And the alpha guy, well, he's not there when there's enough oxygen, when there's oxygen. When there's oxygen, you don't see him at all. But when you decrease oxygen, then you get this guy. And this guy will activate the whole show, okay? So that's why the alpha and beta are important, because it's the alpha. And HIFs are active when oxygen decreases under a certain level, and you start to see them activated. Usually we say, well, around 3% oxygen. So when you hit around 3%, then you start to see these guys get activated. And what do they do? Well, they do quite a few things. And you'll see again all the symptoms that you can think about that you see in anemia. So you have the complex, it activates genes, and genes have to respond to the basic situation where you're lacking oxygen. We need more oxygen, get us more oxygen. So one of the ways obviously is EPO and erythropoiesis. You can change the vasculature too. You can get more blood vessels and hopefully get more blood to the tissues. So that's what's activated also through these factors. Certain genes will do this. Increase cardiovascular responses. We said high heart rate. So one of the ways your body has to react is to be able to pump more blood. Well, hypoxic genes, they do this. They increase blood flow, yes, through more vasculature, but also get the pump going a little bit faster. And also they permit cellular respiration, okay? It's very important for cells to be able to breathe efficiently. And they're able to do this if we change a little bit of their coding and that we force the cells to use well the oxygen that they have. Okay, so basically this is all adaptations. We're trying to adapt the cells to be able to survive in situations where oxygen is changing. And they do this through the hypoxia. And what's more important, and I'm going to bring you to this protein here. Okay, so we're going like EPO, and then the factor that activates EPO, and then the factor that activates HIF, and it's this guy right here. And this guy is an enzyme. And what enzymes do is they modify proteins, okay? And they modify the roles of the proteins or what happens with the proteins. They can activate them, they can inactivate them, or they can destroy them, okay? And this guy here, what he does is he destroys HIF, okay? His job is to change the protein, so this protein is thrown out in the garbage and destroyed, okay? When there's oxygen. So oxygen is present, this guy is active. And so he destroys it, which is good because you don't want cells to respond all the time to a situation where it doesn't need to happen. However, so I'll put a little more detail on this guy because he's very important. Okay. So this guy is a hydroxylase, okay? It's an enzyme. Basically what it does is it oxidates the protein target. So HIF is oxidated by this guy, the enzyme. It modifies the protein and it does this reaction. I won't go into any detail about this, simply to tell you that oxygen is very reactive, okay? You know this, you've heard about oxidative reactions, free radicals and things like that. Well, oxygen is very reactive, you have to be able to control it. So what you do is when you split oxygen, because there's two molecules of oxygen, you have to use one for the reaction and the other one you have to stabilize it. So that's basically what we're showing here. I won't go into any detail on that. But what's important is that when you remove oxygen, this guy can't work anymore because he has no oxygen. He can't do the reaction that I showed you before. It won't work. So basically not working anymore. So HIF, which is important for activating EPO, is stabilized. It's present. Okay, I can go do my work. So he goes and does his work and he activates the genes and he activates EPO. but he activates a whole bunch of other genes. And what's really, really interesting about anemia, HIF and anemia, is that the genes are all the genes that are essential for iron transport. To get the iron from what you're taking in your diet and to get it to the cells that need it to be able to transport oxygen, to be able to bind oxygen, to be able to use oxygen, okay? Actually, HIF prolyl hydroxylase to function needs iron. If it doesn't have iron, it won't work, okay? If I remove iron, this enzyme won't work. So it causes a situation where this protein is inactive, and then you force the production or the stabilization of HIF and the activation of the genes that will need to get more iron to be able to get this enzyme to work. So you can see that it's all linked together. Okay. And so, like I say, HIF and erythropoiesis, it's all coordinated. It's all coordinated actions. So HIF is activated. Yes, you get the EPO response. You even activate the receptor of EPO. And so that's the response that you want to be able to produce new blood cells. But on top of that, you get the iron increase in transferrin, increase in different transporters that are essential to get iron in circulation in the cells, and to bind the iron also and get them into where it needs to be to be functional. So that which brings us to really what's interesting here, and it's that new therapeutics, okay? And that hopefully at the end of 2021, Health Canada is going to accept the proposal of a few companies about these compounds. And these compounds, what they are inhibitors of this enzyme. Okay, so you can start to follow me that you can understand that if I block this enzyme, I will activate HIF, and then I will get more EPO production. And on top of that, I will get better use of iron. So that's their goal. And these compounds have been around for quite a while. And now they're making it, hopefully, they've already made it in Europe, and they've made it in China and Japan on the market for use in treating kidney patients. So the names of these compounds, we won't go into any detail, but the one that's the closest to clinical use in Canada is roxadustat, which is from Fibrogen AstraZeneca. It's the brand name is this here. I won't try to say it. I used to know it as this name here because in the lab, this is what we used to call it. So, but all these compounds have completed phase 3 trials in CKD-related anemia, either in dialysis or non-dialysis, and they're clinically available in Japan, China, and Europe now. So how does it work? I won't go into any detail. I don't want to scare everybody away, but basically it mimics a compound in that reaction that I told you before to be able to permit the activity of the hydroxylase. This enzyme needs to function, needs this to function. And this is, like I said, oxygen is very unstable. You need to use one part of it for the reaction, and the other part of it, you have to do something with it. And this is what you do with it. Basically, you add that second oxygen here to produce another compound, and it stabilizes the reaction. If not, the enzyme can't work correctly. And so what they've done is they've taken this part, this molecule, and they've added onto it. And when this molecule goes inside the enzyme, because basically it binds at the same place as the essential molecule here, well, it blocks the enzyme. It's not functional. And on top of that, it doesn't interact anymore with its target, which is HIF. So it's really a compound which efficiently blocks this enzyme. And now you're saying, well, how can I get, my kidneys aren't healthy. How can they produce more EPO if they're diseased? But actually they can. They haven't lost the capacity of producing EPO. They just don't know how to do it anymore because they can't detect their oxygen correctly. And if they can't detect it, they can't respond. Well, what's interesting with compounds, these inhibitors, is that they're able to force the cells in the kidneys that are present to produce EPO. Okay, and they do that. And by simply blocking the enzyme, forcing the cells to produce HIF, and forcing the cells to, in the end, produce EPO. Obviously, there's advantages and disadvantages of all compounds. So there are some disadvantages to this compound, okay? So it's an orally active compound, so it's a pill that you'll take. Problem with pills as compared to being injected is that when you're injected, well, somebody's there to inject you. You need to take the pill. If you forget to take the pill, or if Teresa, like Teresa mentioned, you're too sick to take the pill and it won't get down, well, then you're going to have a problem of being able to maintain your EPO levels and your blood cells. Obviously, it's always complicated with CKD patients who have problems in the kidney to be able to get the good dosing, because kidneys are essential for the transformation of drugs and the elimination of drugs. So if you have a kidney patient that has quite a few problems, it's difficult for dosing. And obviously there are some detrimental off-target effects. We could discuss that a little bit later. But you know, I was actually surprised because I've been working on this quite a long time, and there was a lot of things that were said as it was developed that this would be impossible to use in the clinic. But surprisingly, the off-target effects are not so bad. You know, if you compare it to EPO, it's not worse than EPO. It's actually, in certain cases, better. There's more beneficial off-target effects, I would say. And so the advantage is obviously it's a pill, so it's easier to administer. There is minimal tolerance. You know, EPO is a hormone. When you inject a hormone, you get a response from, it binds to a receptor and it gets a response. It causes situations of tolerance. Well, this drug doesn't do that because it's basically just blocking an enzyme, not blocking a receptor. You get coordinated erythropoiesis. You get to maintain the iron levels in the body. Hopefully better quality of life for the patients, which is the case and where it's being used. And also some beneficial off-target effects, because HIF does a lot of things. If you activate HIF, your cells are better adapted to be able to respond to situations where you may have a certain level of stress caused by, obviously, oxygen, but other situations. So there's studies that have shown that HIF is cardioprotective. It can protect the kidney also. It can decrease fibrosis in the kidney, for example. Increase the circulation. We saw the blood vessels that were being increased when HIF is activated. So it's a good thing. And also wound healing. Wound healing is a situation where there's hypoxia. Okay, so your body is trying to heal the wound. There's hypoxia and it's trying to get around it. So if you're able to modulate that response and permit cells to adapt, you'll get better wound healing. It's actually something that's well known, especially for diabetic wounds. We know that oxygen and changes in oxygen are very important. So I'll end there. Hopefully I didn't go over my time, and I'll answer any questions. Obviously that stay in the lab. I'll let Dan talk about the clinic, but if you have any questions about what we're doing in the lab, it'd be my pleasure to answer.
Thank you so. Oh, sorry. Thank you. That was amazing, and thank you so much to all our presenters. You know, you all brought something so special to this presentation, and Teresa, a big thank you. You know, Darren really did summarize why this was so important, because you are the face, and this is why we bring you these presentations, and this is why that we really wanted to share this information with you. So we are moving into our Q&A section now, and so please use the Q&A panel or box that is found at the bottom of your meeting window. Preferably don't use the chat box, because we're not monitoring that. We're monitoring the Q&A box for our questions. Anybody who has pre-submitted questions, we will try and get to those, but that's a time permitting. That's with time permitting. And also please note that we're unable to provide any specific medical advice for specific issues. And sorry, Teresa, I did interrupt you, so I'll let you speak now before we get into the questions.
No worries. I was just going to say that was a very interesting presentation. I'm not sure I followed everything, Darren, but maybe we'll have a chat later. Certainly, some exciting new things. If it was a pill, it would make it easier for patients to take. I know a lot of patients object to giving the injection or having it, and it's really very minor, and I learned to do it, no problem, but it can be a barrier.
Yep. There's a question in the, can I answer the question that's about in the liver?
Of course, please.
Okay, so in the liver, yeah, liver, as we grow older, we lose the liver and we gain the kidneys. So basically, in the embryo and during development, it's the liver that's producing EPO. And yes, it's been shown that these compounds can force the liver to produce EPO. Yeah. So yeah, it will push the cells that are able to produce EPO will be able to produce it when they're treated with this compound. And obviously, the liver. The interesting part with the liver and the kidneys is that these compounds have to be transformed. The kidney is the tool, and also the other tool in your body is your liver. So these compounds are going to go to the liver, they're going to go to the kidney. And so that's why it's interesting also on that side of it, because the cells are going to see a lot of compound and they're going to react to that to produce the genes that are regulated by HIF, but EPO also. That's a good question.
Yeah, and to add to that, in adults, the kidney typically produces 90% of the erythropoietin and the lungs 10%. But as we, embark on this new journey with these new compounds, we'll learn, if a patient doesn't have any kidneys, just how much does the liver take over in the regulation, and how can we modulate that? We're on a new and exciting learning pathway for this as they come into practice. And as Dr. Richard mentioned, they are in place in a few countries around the world. So we will obviously take our learnings from them in the clinical situation.
Thank you very much. And we've got quite a few questions coming through. So this is really great. But I'm going to start off with a pre-submitted question about tiredness, because I know patients are really concerned about this as well. Maybe Teresa, you could start with this. How did you manage the tiredness, or how do you manage the tiredness?
Well, I think I shared a little bit about how I manage the tiredness with breaking up my tasks into smaller bites, taking rests in between, making sure I do get lots of rest if I have a bad night or something. Occasionally, I do take a sleeping pill just to help me sleep if I'm having trouble during a week particularly, but it's not my regular routine. And I do try and do a little bit of exercise. I don't know if it improves my anemia or not, but I find it helps my stamina to manage it better. I get a little bit longer when I do regular exercise, and it's very light exercise. I'm not talking about strenuous. My favorite thing to do is to play Wii games, physical Wii games, not the just the push button ones, or go for a walk. But that's the type of exercise I'm talking about.
It's a good point, because I said that kidneys are the sensors of oxygen in your body, and your other sensors are your muscles, because your muscles consume a lot of oxygen, and your body will react to that. And it's very important to be able to maintain the level that you're able to do of exercise to maintain the way your body is reacting and to the changes in oxygen. So yeah, it's a very important part. I saw that also in the question. Does regular exercise help with anemia?
Yeah, and in terms of the fatigue, and then doing exercise and getting into a vicious cycle of getting more fatigued and just running yourself down, yet you're trying to exercise. What I say is, if you feel good that day, do 50% of what you think you can do, and have a check-in so you don't overdo it and pay for that for the next 2 or 3 days. Everything is in a stepwise fashion. You don't need to go out and run a 5K when you start exercising. I think, everybody has their tolerance, and just do 50% of what you think you can do, and then go from there.
Agreed. Sorry, Lydia. Sometimes I start with as little as 5 minutes because I'm just not feeling well.
I see a question about taking iron supplements and the ferritin level goes way high, and yet not absorbing the iron. And this could this be from having an ileostomy? So I'm not going to comment on the specific scenario, but certainly ferritin is a marker that we look at for anemia, but it is also what we call an inflammatory marker. So it will go up when our bodies are inflamed, and our bodies can be inflamed from a number of different conditions. So the ferritin, we have to keep in mind that if it goes up, it may be due to this inflammatory, and the inflammation, we may be willing to accept a higher ferritin knowing that, but it is a balance, trying to get the stores of iron up and the transferrin up and the utilization of the erythropoietin. You need iron for the erythropoietin to work, so it is a balance that we always take a look at.
Okay, thank you very much. And we've had a practical question as well come through, and it's about how to pack EPO when traveling, for example, more than 5 hours. And if there are any hints or tips to our audience today.
I'll let Teresa take that one first.
So I would always pack it in a very small cooler like you would find in the dollar store, or even any of the stores would carry them, like a lunch box cooler. And make sure I had an ice pack in there, and that seemed to work just fine for me.
Yeah, so we don't want to freeze the product. We want it to be a refrigerated temperature, so 4 to 8 degrees Celsius, and you do your best in keeping it that temperature. There is some tolerance up to 24 hours out of refrigeration for the product still being, okay. So, but don't take that as I'll throw it in the dash of my car and travel into the desert and then take it, then 24 hours later. Don't do that. Do your best to maintain that cold chain requirement. If you are traveling, carry that on your person in a little cooler rather than, not in your checked bags. If you do happen to fly in a plane, which I don't know, I haven't done in a long time now.
Yep, I think flying in plane is a distant memory for a number of us here today as well. I've got a question also about iron, and can iron supplementation help when somebody's hemoglobin is still normal?
Yeah, that's a great question. I'll tackle that one first. When we start to use erythropoietin or darbepoietin, there is a pent-up demand to produce red blood cells, and so suddenly the bone marrow is stimulated to produce these red blood cells. So you can get what we call a functional iron deficiency, where this pent-up demand takes up all the iron available to use for red blood cells, and the iron levels drop. So we actually, I think of administering iron a bit like, for those of you who might be diabetic, is sort of the baseline insulin, where you have a baseline amount, and then in times of need, we might top that up with a dose. So it's good to have a baseline amount of iron in your system so it can be utilized to make hemoglobin. So taking iron as supplementation, even though your iron levels are okay, is actually a strategy we use.
Okay, thank you very much. And then also along the lines of iron, and this is getting into something that you mentioned, Teresa, was what do you think of using cast iron pans to increase iron?
For me, that was the thing that helped most significantly. I struggled with the diet, as I think Dan mentioned. A lot of the foods are high in potassium and phosphorus that are high in iron, so I was limited in what I could eat in high iron foods, and the pan helped me. Whether it's medically recommended, I'll let someone else speak to that.
So as a pharmacist, I can't give you a dose that your iron pen gives you. So that's my caveat. However, you know, we all maybe cook a little differently with cast iron pans and how we season them. And by seasoning them, you're sort of sealing, making a non-stick surface in a way. And so you may not be getting as much iron. But certainly, I think there is a transferring of some of the iron when you cook. But I can't tell you about the dose, but I'm glad that Teresa was able to manage with that.
That's great. And, you know, as always, any specific dietary advice should really come from a dietitian. There are renal dietitians attached to most renal units out there, so feel free to reach out to your dietitian. Also, the Kidney Community Kitchen has Ask a Dietitian questions, so if you have specific diet questions in regards to iron as well, and managing your other components like phosphorus and potassium with those high iron foods, feel free to reach out to the dietitian group, and I'm sure they'll be able to help with your responses. Unfortunately, we just don't have one on today's panel that can help us out. So that there is that. And that was it for the formal questions. I think we had a couple of questions in regards to when the new agents might be available in Canada. Dr. Richard, did you want to speak to that? Or
I answered it in the form, but it's supposed to be going in front of Health Canada panel in December. It's been there before. It's been there for quite a while, and they had a little bit of problems, and the FDA asked them to do a little bit of additional work, and now it's supposed to be in December. That's what they're waiting on. So that's the basic what I've heard. I don't know if Dan has heard anything differently, but I've heard December.
So that's one side of the pathway. You know, each provincial, the provincial plans will have to evaluate and incorporate, and then the private insurers will have to evaluate and incorporate. So I would say it's likely we see availability in 2022, but I don't know, nor do we know the pricing of these products, how we're going to incorporate them into care, who would we choose? So will there be criteria? So there's a lot of work to get there, but I think all of us anticipate that they will be used, and we will be offering them in some fashion, but it's a little bit of a crystal ball at the moment, figuring that out. I saw a question or a comment about, I don't like our dialysis unit anemia algorithm, too low for me, and appreciate that. And managing an anemia algorithm or patients within an anemia algorithm it can be a little tricky business. We take our cue from the published trials of safety as well as efficacy or how well a drug works to inform how we have an algorithm, and we try to keep our patients within a 20-point range of hemoglobin, and some algorithms will have that as 95 to 115 grams per liter, and others 100 to 120, but it seems like 112 is where we want to start dampening down because of the potential long-term effects of the erythropoietic hormones. And we recognize that, as Teresa mentioned, if the hemoglobin's below 100, you start to feel it. Other people may not feel it till it's below 95. Other people might feel it when it's below 105. It's very hard to individualize an anemia protocol. So we do our best, and the conversation about how you feel, what you're able to do, you know, have that with your nephrologist physician. Talk about this with your pharmacist. It may be a play of the iron utilization as well. But as with most things, we try to treat 90% of the plus of the people well with a protocol, and some people will feel a bit fatigued. I don't know, Teresa, if you have any comments. Oh, you're on mute.
Thank you. Sorry. I think you said it very well, Dan. It's always best to talk with your nephrologist. I know as a self-advocate during my kidney journey, I have advocated for stuff that is outside of the norm when it worked for me. And that is a possibility generally with most everyone.
Thank you. And just before we wrap up, I just wanted to comment again, Teresa, on how you have self-advocated and empowered yourself, and what a shining example you are of being able to overcome so many obstacles. And thank you again for sharing your story. I think what stuck with me the most was one of your quotes, and I wrote it down because it really did touch me, and I think it was so important, and that is, life is too precious not to enjoy the moment. And it's a wonderful mantra to live by, and I really do appreciate that. So on behalf of the Kidney Foundation, thank you very much for joining us, and to our speakers who have joined us today. Feel free to reach out to us at kidney.ca for things such as the Kidney Community Kitchen for recipes or dietary advice or information. Also, feel free to reach out to our regional branches for advice and support about accessing services within the healthcare system, assisting people to access supports in their community, and offering assistance in skills for self-advocacy. Please reach out to us if you have any further questions, or if you'd like to speak to somebody within your community, or just want to have a bit of guidance how to access some further information and education tools.
Thank you everyone for attending this webinar, Understanding and Managing Anemia and CKD.